Hey, Dr. Metzger. Karthik here. How are you?
Hello. Hey, very good. Chris Metzger and crew will introduce in just a moment. Do me a favor, before we introduce our team, could you tell me who's up there on the panel, and then we'll introduce our team and get to work.
Oh, that's what he said. Okay. So we have Dr. Garcia on the panel here, Jan Gafik, George Cresant, Peter Sokos, Jose Wiley, Steve Coombe, David Song, and Mariana Broadman. A full panel.
Wow. Okay. Well, you think? A full panel, international multidisciplinary. I love it. Well, welcome back to Kingsport, Tennessee. Great to be back with my brothers and sisters here. We just rejoined a couple weeks ago. I want to, before we start with the second case, I want to introduce a team that did a phenomenal job, not only with a tough first case that a lot of you saw, but flipping the room in record time. So thank you all, and let me introduce them. To my right here, first starting here, Dr. Gaurav Rana. Truly a brother from another mother. He is a phenomenal interventionalist in our mitral clip and tricuspid clip, but he kind of does it all. And you may see him in action here depending on how we do here. To my right, running the table, Courtney Jones. Hardest job keeping Rana and I under control. So Courtney, thank you. Behind us, we have the talents of Holly Bragg, the talents and hair of Sydney Albany, and the talents also of Allie Gray. Again, phenomenal team and industry folks as well. So let's go to our case. Let's show the slides. Let me know if you see the slides, please.
You're excited? Yes, please. Yes, we can see the slides.
Perfect.
I'm excited for this
Okay,
case.
great. Next slide, please. My disclosures haven't changed since the first one. In fact, I think somebody erased me after the first case. Next talk, or next slide. All right. Very, very nice 67-year-old female. No known prior peripheral vascular disease. I'm going to need your help on this, y'all. No coronary disease. She does have a history of tobacco, long-standing, and her BMI is at 42. Dyslipidemia, but she has not been diabetic. She did have a history of an emergent right ovarian surgery 4.5 months into a pregnancy with a lot of hernia and incarcerated bowel issues and extensive mesh. But otherwise, very healthy, nice gal, works as a hairdresser and such. She had a series of unfortunate events in early July. The first one was she dropped a heavy metal case on her bare right great toe, opening it with a significant injury. Within 1 week, she has a large pit bull who stepped directly on that wound, often or also with a bare right great toe, making even more significant injury. And so she had a wound there and very significant rest pain. Interestingly, no real antecedent history of claudication prior to that. So we have no idea how long some of this has been going on. She goes back and forth with her husband, Jose, to Florida. She has a right toe that's painful and purple. She's been to the urgent care 4 times, both in Tennessee and in Florida. Next slide, please. She's been treated with multiple antibiotics, Bactrim, clindamycin, doxycycline, anycycline, and really not helping a lot. Still, the wound hasn't healed, and she has a lot of rest pain, which is all new. A first podiatrist suggested we just take her great toenail off, which she fortunately declined. And she came back to her PCP in Tennessee, who got an ABI, which was 0.45 with a TBI of 0.32, really pretty normal on the left. And again, no history of known peripheral vascular disease prior to that. She has ongoing severe rest pain on analgesics and still on antibiotics. Podiatry number 2 said, hey, get her in, let's get her some flow, and hence here we are now. CT angiogram, which unfortunately I couldn't get our equipment to interact to show you, but it basically shows a long right SFA CTO with probably a tiny nub, fairly small caliber vessels, and after reconstitution, pretty decent runoff vessels. Next slide. And this is a picture of her toe. That's after the pit bull and the can, and again, you see a little bit of involvement in the second toe as well. Next slide, please. Okay. So that's where we are now. We flipped the room like we did last time. In fact, we kept it in the flip position, so you see me working backwards. We're going from the left leg, working on the right, standing looking forward, keeps my back straighter. This is the first time we've done this in Tennessee, so again, everybody roll with the punches like nobody's business, and here we are. Let's show the fluoro now, please. Let me just get, so vascular ultrasound-assisted micropuncture access. And now, here's abdominal aortography, looks good. The renals are okay. Yep. Aorta iliacs, look fine. Here's an RAO so that we can separate. You can see that tiny little nub, and there's a branch there as well at the ostrom, the SFA. Okay, and then because of the room scenario, we just did these by hand here starting at the ostrom. I hope we can see a nub there we haven't probed yet. A little bit of premature injection on my part. And here's the reconstitution with some disease at the reconstitution and a significant branch, which sometimes makes it a little harder to get into that antegrade. But I've got Gara Vrana in the wings in case we need to come in the other direction. And then as we go down, kind of small vessels, but the trifurcation's okay. And really, while there's a delay, the ABI was 0.44, there are good runoff vessels down there.
Vessel runoff.
And here is another picture enlarged. The PT is kind of a dominant vessel, but the AT does come in late. So again, no idea, folks, how long the CTO has been there. It was manifest only when there were 2 injuries in the same week. So any thoughts from the panel, and then we'll probably get to work and try to cross that occlusion. But any panel thoughts are welcome.
The panel. I think it's just all smokers' disease, right? No diabetes, so it's just long-standing smokers' disease, large vessel. George, any comments?
Yeah, I mean, I think probably he's been there for a long time and just took an injury to bring it out distally. So I get what you're saying, though, Chris. I mean, sometimes in these histories, if something has changed in the last couple of weeks, then you worry that maybe there's something a little more acute on top of the chronic, and then that may change your strategy on devices and so forth.
Right.
So I think
don't
everybody
that
agrees
was
with
the
your
case.
plan, I think.
I think the acute bit thing was the pit bull.
Exactly.
It was a cute pit bull, but it was an acute event from the cute pit bull.
So Dr. Metzger, what catheter and why are you using?
Yep. The interesting to see on the panel is I like an angled Navicross and an angled glide wire if we can. Now that's getting some resistance. And this one's a little tough, folks, because I'm not positive these aren't little branches, and you don't want to overdo things in a branch.
Right.
We'll see. Now that looks like a SFA. Okay. A loop longer than I want. Go ahead and fluoresce that. Take the smart map off and go
Angle catheter, glide wire, and raw force.
Now, what I'd really like to do, and love to get other strategies here, what we'd love to do is stay in the true lumen if at all possible, and at least be very close for re-entry if we have to. And I'd love to get the panel's decision or perspectives. Depends on what kind of devices folks are using these days to get back into vessels. And at what point we'll also keep in mind the entire time of at what point do we go retrograde? And I will say I don't really like the way this loop is behaving.
Mm-hmm.
You'd like to keep it tighter than that, and we'll see. And her vessels aren't that big to begin with, so I don't particularly care for this behavior. But we'll see if we can't get it.
So you're losing the loop intermittently?
All right, now as we get closer here, we're going to make a road map and see how close we are and see what we can do. And we might use your catheter in a moment if we need to. All right, go ahead and so just hit the right road map button. Yep. And I'll have you inject in just a moment. Okay, inject, please. Great. And, I think it's important. I'd love to get others' perspectives, but I think it's important to have a ruler on here and know where your re-entry point is and not just keep pushing.
So, Dr. Metzger, a question. You're not worried about losing that collateral, right? Because there's another big collateral down there.
There's a bunch, exactly. There are other collaterals below. Now, here's where I like having the angle. That's clearly not in where we want to be. Get ready to open your catheter. And here's where an oblique picture will probably help us see
just
how
spiraling
close we
around
are
the
as
vessel
well.
wall.
But
There you go.
Don't open it. Don't
Yep.
open it.
Very nice. Beautiful.
Okay.
Very nice. Beautiful. That's a great demonstration.
Well, and thank you. We've got the bee back over here, which is, I absolutely love, and learn from it, Marianne, from our European colleagues. Take the smart mask off.
Yeah, just to let you know, Dr. Metzger, PK has a huge smile on his face here, so that you got through, you know.
You know what? And that is one of the prettiest smiles in the universe right there. It is absolutely beautiful. So
Chris,
if I made PK smile, man, my day is already made.
I know, right?
Chris, he's holding up a sign that says
From the
"Flattery
panel,
will get you
you
everywhere."
guys have any other comments on how anything different you guys would do in the way? I mean, he did it perfectly the way it's supposed to be done. But again, if you guys have any other techniques,
Now,
Anything
let's see what we're going to do here, because this vessel is pretty small. Let's start with give us a Grand Slam exchange. And let me have this,
I think
and we'll take a picture of it, and then we'll take a
No, I think that, people used to, I remember some live case, people used to start with a 018 intraluminally, it takes time, and after 5 minutes they push, they have a loop, and they make the re-entry. So do not hesitate for the younger people to make a loop, it's pretty efficient.
17.
In 10% of the cases, you don't succeed to make the re-entry, you can make the retrograde approach, you can use a re-entry device, but loop is safe, it's quick and efficient, so.
yeah.
You should not be blamed because you use a loop to make the re-entry. I think it's a very good example for that.
Just like you spoke in your talk. Yeah, exactly.
Chris, great procedure. Quick question. When do you decide to use a re-entry catheter versus retrograde
Smart.
access if you wouldn't have been able to get in?
Let's have this and the shaper.
Dr. Metzger, I think Dr. Wiley is asking, when do you decide between an re-entry device versus a retrograde for the patient?
Yeah, no, I love that. It's a great question. Here's the deal. I think if you're very close to and that's where I was just about to do an oblique view, because if you're close to the vessel, I mean, you're right there, and I think the B-back has kind of revolutionized things, because instead of going beyond the reentry and then pointing back, you can actually aim forward with a needle. It comes out, I think it's 11, and it's a sharp needle, and it's a braided catheter, so you don't have to go out. So if you can go straight, I even like that, and it's angled. So where we were, if we couldn't get there, he was just about to crack the seal, and if you did, I'm sorry, but we're not paying for it. But no, no kidding. You can angle that catheter. The C shows you where to go. Let's have the torque in the back. And then we go. If it's really far away and you can't get anywhere, then a low threshold to go retrograde. Especially as has been mentioned, and I'm going to look over the side because I got an accessory monitor here. Let me have a torque, please. Especially if we're going to lose a collateral, and we've got 3 tibial vessels here. No, that's orange. That's 035. We need an 014, please. 014 torque, please.
Chris, this is Mary, and I just would like to ask you one question. I mean, this is a CTO. Do you consider IRIS, to see if you're interluminary or subintimal at some parts with regard to the upcoming, I guess, atherectomy procedure you want to do in this long lesion?
Yeah. Hey, Phil, could you turn up the volume from New York? Because I'm having
Dr.
a little trouble.
Metzger,
I heard the question. Go ahead. IVUS, I heard the question, and to some extent. And I think IVUS is invaluable. If anybody was watching our first live case, for whatever reason, and I don't understand all this, I'm not a smart guy, but we have a decompressor for our videos, which doesn't play well with our IVUS. We've never had a problem with IVUS for live cases before, but whatever this is, we're having trouble. So IVUS may or may not be an option, but how do you think IVUS would help you here, Mary? Just take that off and go AP.
Dr. Metzger is asking the role of IVUS for you.
Our role of IVUS.
In this case.
In this case, we would do IVUS, to be honest, especially to decide what kind of following therapy strategy we would apply. So I feel more comfortable with IVUS in the CTO lesions. So we are more going to IVUS usage after crossing
Let's take
CTOs.
the 4 by 120 chocolate.
I just want to ask a panel a question. Chris, this is PK. How are you? Just for the panel, I mean, with small vessel disease like this with a woman, you know, it looks like at least angiographically a diffusely diseased vessel. Are you worried about scaffolding? Are you going to be leaning more towards drug-coated therapy in this type and leave nothing behind, or is that not part of a thought process? I'm just curious on how you attack small vessel disease, smaller vessels, not small vessels, but smaller vessels.
I think what
Yeah, that's a great question. Because I
happened
think
since-
you're right. I
what
love Sapera or nitinol drug-eluting, but with a smaller female vessel, I would much rather get by with leaving nothing behind. So we're going to try to atraumatically prep the vessel. So bring that up.
Jan, your
So
thoughts?
we're going to go with
Chris,
so
1 second, Chris.
without IVUS.
1 second,
Yeah, go
Chris.
ahead.
Chris, 1 second.
Please.
Jan?
No, I think that I have a French expression for that. I don't know if it makes sense for you. We should put the church in the middle of the village. So since few years, you know, you discuss about living or not living something behind.
Not
It's completely
chocolate.
crazy.
Chocolate.
It's not
4 by
about to
125.
live or not to live. It's to achieve the best outcomes. If with DCB or leaving nothing behind, I have 100% of patency at 1 year, it's the best treatment. If using a stent, I have 100% of patency, it's the best treatment. It's not to live or not to live, it's to achieve the best treatment. So, and many discussion is to discuss about to leave something behind. No, it's to achieve the best treatment, whatever the device is used. It's not a problem of leaving nothing behind. We are not living in a green world. We are physicians, and we should focus about the outcomes.
Dr. Sokos, any comment?
Yeah, I echo Marianne's comments about IVUS in terms of vessel sizing, and it is helpful to determine if you're intraluminal or if you're in and out. That may have a role in terms of whether or not you choose to use atherectomy. If you are sort of in and out and you have a reasonable distal lumen, I mean, this is a pretty long lesion, so I would, to echo Jan's comments, I mean, you want to give this patient the best result that you can long term, and in my mind, that's going to be ending with some type of drug technology or a covered stent.
Dr. Garcia?
Yeah.
Yeah, you know, I mean, there's brighter IQs on this panel than me. At the end of the day, I think that this is long, and I think you need to get the best lumen you can. I think the durability, whether it's drug-coated balloon or drug-eluting stent, is going to be, either one is probably similar. The question is do you want to go back against a stent, or do you want to go back against a stenosis that has nothing? And for me, even when it's long, if it ends up being a reasonably good result, I like a drug-coated technology that would be drug-coated balloon. I think that's the best way to go.
Okay, ready?
Steve, what do you think? Would you leave anything behind?
A lot of ways to cook this, but I think the underlying thing is we've got a smoker who has got a small blood vessel and not too much calcium.
Okay.
So drug-coated balloons would probably work here. So
You good?
I personally would go for an early retrograde to stay intraluminal and confirm that with IVUS if necessary. And then consider some form of a atherectomy device and maybe stent the top and DCB a lot.
You good? You got
But
wax,
because although I'm a pro stenter for CLTI, if you look at the size of the wound, it's a pretty small wound.
You got the wax.
And I'm probably inclined, if I can help it, if I get a good result with balloon, to stay with drug-coated balloons. Of course, if I don't get a good result, as Jan said, it's a full metal jacket drug-eluting stent for me, at least in my practice. But that's just my preference.
Yeah, and I think that the key on the whole IVUS sizing thing is that we know from also other vascular beds, coronaries in particular, that when you cross a CTO, the distal vessel, you're fooled. And once you reopen everything, the vessel's actually much bigger than you think. So the common theme here that we're all getting at is the best result is going to depend on how big or small this vessel is, because we know the data on stents and DCBs by diameter and length. And so I think knowing for sure what you're dealing with is very important.
But to the trainees.
And another argument from my side is that this is a patient who has an untreated diabetes. So until the point we really will have her at the level when there's no atherosclerotic activity, I think therefore we need to do the best thing, just to keep this really long occlusion open.
Yeah, to be pragmatic and to the trainees, I mean, you have to have a philosophy, and whether, I agree with you that as a physician, you shouldn't accept negative outcomes. But you have to have a philosophy in approaching things. So leaving something, the diameter and the smoking plays a role in long term, regardless of the technology that you will use. So you have to have your philosophy. I think it's like Dr. Lawrence says, predictably, this critical lymph thread ischemia is a wound. She wasn't a claudicator before. All you need is oxygen delivery to heal the wound. That will be your, and then the patency becomes a secondary clinical issue, becomes a hemodynamic issue, but not. So, crossing successfully, vessel preparation, and then definitive treatment with coated. It's dealer's choice, really, in terms of dealing with the recurrent stuff, but leaving enough flow so she can heal the wound. If you want to be cost effective, probably you do drug coated, and then you see if you have a complication, you address the complication maybe with segmental stuff, because again, long segment disease, the scaffolding rate of use is higher. So you need to be prepared to deal with all the aspects of it, but you have to have philosophy to start.
Great comments. So, Dr. Metzger, you want to update us what you're doing? Looks like based on the way you
I
took
sure
its
will.
chocolate
I
balloon.
agree with all the comments. And the one thing I'll say is, boy, every one of you that says IVUS, I agree. I want to cry when the whatever this thing is smarter than me, the decompressor of the video and the IVUS don't play well, because I feel almost Tennessee naked here without it. But what we're doing now is a chocolate 4x120. And what we did here is we go up on a road map here. See it right there? So, and remember, we also had the CT angiogram. They're not perfect measurements. It looked like a 5. That's small, okay? So in a perfect world, we would like to do a long, slow inflation, okay? And then come down slowly, come up, open it, and reassess. And then together we'll think, and again, I'm naked without the IVUS. I don't know what else we can do here. But we'll take some good pictures and then decide together, do we want, normally I like interwoven stents, but I don't think we can make this big enough to make it worthwhile. Start slowly coming down. And so I think what we would do is use Alluvia or Zilver PTX if we had to scaffold in this vessel, because as everybody said, the drug is that. If we can make this look good, then we're going to do long drug-coated balloon inflations and get her blood to heal that wound and then live to fight another day. We need to light that load later.
Yeah. Dr. Metzger, I think as you continue doing this with the chocolate balloon, we're going to do a talk and get back to you. Is that good?
I think that's perfect because I want to do long inflations. Thank you.
Thank you.
Okay.
Dr. Metzger, hi.
Yes, sir.
We are back.
We're,
you want to update us?
Let me take another picture and then we'll update everybody. And then they tell me that they can turn their stuff off to get an IVUS. So we'll see if they're... So
Okay.
to me, it looks like we're going to need scaffolding regarding... I almost don't know that we need IVUS here. Let me go back and show you. So what we did is we took a chocolate balloon. It's only a 4x120. Long, slow inflations at nominal. Went to the bifurcation there. And long inflations. And if it looked good, we were going to just DCB. We can IVUS this, but I could tell you, we all know what we're going to see. Happy to show you that. But I don't see any way, especially with that, kind of where we re-entered, we had a little bit of loop there. I think we're best to just put drug-eluting nitinol stents in there. Is there a consensus there? I don't know what our time is. Yeah. We can show you quick. We could try. Is the IVUS hooked
Yes.
up?
Anybody from
It
the
is?
panel? Any comments?
No, absolutely.
Yes.
We have
Everybody
data
with a
now
silver
since the release of sports
Six
to
by
be
140
looking at
silver
the long lesion. So I am not surprised, and if you look at the DCB also outcomes when you treat long lesion, it's about 50 to 60% of bailout stenting. Sports is very impressive, done by a German guy named Gunnar Tepe, with 50% of difference in terms of restenosis after 1 year of follow-up between DCB and DS in favor of DS. So
Okay.
I think for long lesion, definitely we need the scaffolding.
So I just have a question for the panel. I mean, is the vessel prep adequate with that amount of recoil? Do you think a standard nitinol stent or a covered stent would have enough, or would you be more aggressive with vessel prep here?
I would be more aggressive.
Yeah, I don't know. I think that if you're going to drill it now or if you're going to cut it now, it does become a little bit of a challenge because I don't know. Maybe this is the time for IVUS. because I think you have a type C dissection downstream, but a type B proximally, but a lot of recoil.
Yeah.
So I'm not sure that you're going to gain a lot with just drilling it. I think there I would just put a stent in. I think there's enough, because the balloon expanded nicely.
Yeah.
I don't think you're going to gain a lot more with that. That's my opinion. Anybody else?
Yeah, and it was a specialty balloon. It wasn't just a regular balloon.
Yeah,
It was chocolate.
exactly.
So I agree. I mean, it fully expanded.
All right, can you hit record?
You know, the chocolate balloon's really kind of cool in the sense that if anybody does angioplasty, those pillows is the only time in my lifetime that we have a volume to pressure balloon, whereas whenever they give you the nominal, it's always in air. So this one goes to a volume to the pressure you give, and it's maintained. Those pillows are not to grow. They're actually to stay the same size. When it gets to its nominal state, it's actually pretty good. I like that design of balloon.
So I think Dr. Metzger is waiting for us on the IVUS. Right, Dr. Metzger? You're ready with the IVUS?
Yeah. So we've got an IVUS. Unfortunately, the only way they could get it to work is to disconnect it, so we can't show it through the floor. But I'm going to have our camera guy, who's very good, carefully maneuver his equipment.
Yeah, we'll turn the heads too.
Cool.
So you can turn the camera and we're
Yep.
going to turn the heads.
That's what we're going to do. Otherwise, we'll FaceTime you.
That works.
Yeah, plus, I get to see PK's smiling face, so it's worth it. All
See,
right, tell me when you see
twice
it.
in a row you got PK smile. So there you
I
go.
know, this is great. All right, can you see that?
Yeah. We
All
can
right,
see
ready? All right, now hit record, please. All right, so this is, and put the fluoro next to it, please, so they can see right on fluoro on one and IVUS on the other. And you can see a dissection right there. See that? There's one way to fix that, and that's with a scaffold, I think. Right there's a dissection. See that right there?
Yeah, clearly.
Can everybody see that?
Complex dissection.
Yeah, and there's a little kind of almost a intramural hematoma and a dissection. So go ahead and open the Zilver PTX, please.
Okay.
Yep, okay. Good. Turn off the recording, please.
Any comments, Dr. Brogman? You wanted the IVUS. The IVUS.
I would have done it earlier.
I was expecting that answer. You know. Dr. Metzger, you're a little late on the IVUS. She wanted the IVUS before ballooning.
I heard that. And I tell you what, if she was dealing with the furniture situation in Kingsport, I'll heckle her the next time. But no,
I was going to
I think
tell Dr.
IVUS is
Broadman
a
that
good
men
thing.
are always late in getting what women want. But
Real quick,
She knows men are
Yeah,
always late.
that's completely
Yeah,
true,
hold
to
the
be honest.
Camera, let me wait to watch.
Chris.
Hold this IVUS cap.
Chris, it's
Yeah.
Samsky. So I think you got to, at your re-entry point distally, you've got a dissection there that you're going to probably have to scaffold. And then your sub, I mean, you were sub the whole way through, it looked like. It's hard to tell sometimes, but if you put the ChromaFlow on, you can see you kind of have that crescent shape around the lumen. And it looked like maybe plaque, but I think you were likely to sub up until your flush SFA. So I have to give the debate next about DES for long segment occlusive disease. I think scaffolding this isn't a bad idea, but at minimum, you probably have to scaffold that distal portion, and then you can see if you can keep it open with the DCB proximally. I mean, I think you end up scaffolding this, is my guess.
so my only question to the panel is, if the patient has a 3-vessel runoff, right? So scaffolding the whole thing would probably give a more better patency for the patient than spot stenting it. I mean, why leave
I think so.
any questionable part of the lesion alone? What do you guys think? Runoff is like very good for the patient, to the foot.
Yeah, I think total lesion coverage is the key here. I mean, it would be nice to go with a stent-free approach because there's actually very little calcium in. But since you've got a mechanical problem,
Right.
then I think you're going to need a scaffold. And if it's
Hey,
going to be a
King, sir,
scaffold, it might
get a
as well be a
5 by
dynamic
long
stent
Sterling.
based on the data we have from sports. The only problem in this
Okay, ready?
case that is
That one?
unknown is this is a small vessel compared to the vessels that we probably had in sports.
Right.
So the question is a oversized 6 mil DES going to work in a sub 4 or 4 millimeter vessel? Because that chocolate was a 4, the distal vessel looked a bit small. So I don't really have the answer, but probably it will work. The other comment I wanted to make, I think PK, you made a comment, is the vessel prep enough? I would argue that it's probably a little bit better to be more conservative in vessel prep in this case, because if you have a rupture, you will have an aneurysmal formation with time. And the data seems to suggest that from Japan that if you have a subintimal recanalization, a higher risk of an aneurysmatic change with the drug.
So I think PK's point was, I think on the IVUS also, you see some areas where you are luminal and you have some atherosclerotic plaque. I think he's concerned where the area has a lot of recall. I think he's probably thinking that area is probably more plaque
Yep.
burden, right? Am I
And
right?
also, when you're subintimal, and Jan, using the Boston Scientific stent in the subluminal space, could that lead to aneurysmal formation, especially if you're oversized with a 6 millimeter stent in a 4 millimeter vessel?
So far in my practice, I didn't observe this. So you don't look also what you don't search, but I did not have any trouble with such pseudoaneurysm. Just, regularly people say, okay, stent prevent surgery. I am vascular surgeon, perhaps I have different education from different colleagues, but in my routine practice, I was educated, okay, when you perform the distal anastomosis, it should be a free disease zone. So you open, you touch the P1 segment, and you select a free disease zone, so without any classification, to perform the distal anastomosis of the FEMPOP bypass. What I mean here, the stent usually is located at the disease zone, not disease zone. And so it's why, a stent is not a concern to make open surgery.
Dr. Metzger, the sizing of I think the panel is talking about the sizing of the stent. On the IVUS, you have an IVUS now, so
Yep.
can you tell us what size you got of the distal vessel?
It matched. Yep, it was 5.2, and that was very consistent with the CT angiogram. So I think 6 is the right way to go. We're not oversizing it too much. It's a small vessel. I'm with Eric. We could spot the end all us wanting to be cute, but it's not going to be cute at the end. So we're just going to put 2 scaffolds side by side, cover that, and then post-dilate them so we get luminal gain and try to diminish recoil. I'm not a huge fan of nitinol stents, whether they got drug or not. By the way, that was just a measurement with the Navicross, so we could pick the length of the next one and not overlap it too much.
I'm guessing the fact that you put a 6.0 stent.
I'm sorry?
Did you put a 6.0
I feel good
stent?
about a 6.0 stent.
6.0 silver?
Yeah, I don't like 5. I don't know that I've ever put a 5.0. We'll need a new Navicross maybe. All right, let's take our PTX. What size what would the panel think based on 5.2 on the IVUS and what you've seen on the IVUS and what you saw with the 4.0 chocolate?
Chris, would you have considered an interwoven stent since you had some recoil there as opposed to this night?
Yep. Yeah. I love interwoven stents, and I think in order to do that, we would have to hit this pretty hard with a 5.5. We've already heard about the little bit of rupture there. We're subintimal. It is something, and the nice thing about that, you got wire? Yes. Okay. The nice thing about that, we don't have a long 2 nitinol stents that could fracture later. But the stent fracture rate does seem to be going down. The data on long drug-eluting stents is pretty good. So now, next step here is to nail the ostium here. We don't want to hurt that profunda. So we're going to zero in. I know I've got a little bit of overlap here. That's exactly what we want. And now we're going to just fine-tune the proximal part. I'm going to mag up a little on the proximal. And let's see here. Can I get that alarm, please? Thank you. That's probably going to be a little high. And I won't do that, by the way, folks.
Little more.
Hold the wire, please. And I'll probably get a little more angle. Okay. Take that one off. We'll get it. And then we'll get the panels. Watch this, please.
So we went from leave nothing behind to a full metal jacket.
So
Thanks for observing that.
I'm
Yes.
just curious, like how many in the panel would, as like Eric was suggesting, would do full metal jacket or just spot stenting? Let's go from Dr. Garcia. Let's start from you.
I think I said it before. I mean, I'd love to leave nothing behind. And many of these, if you just had a type B dissection, I think that you could get away with that and walk away. That's kind of where they were. If you look at Macari for DCB, long protracted pre-dilatation left, instead of the global using 40% stents, they were down to 17% stents on a 17 or 18 centimeter metric. I can't remember. But here, I think you had dissection proximally because the entrance was not optimal. You had this really kind of long recoil segment in a type C dissection downstream. So I think you have to play. I was trying to be cute, but at the end of the day, I think you have to go with the uniqueness of the artery and the artery that you have. And I think that here, stenting is probably the right choice, is where I was going with that.
Jan?
And you're always cute, Lawrence. I'll get this tape out of the way.
But what happened in
You
real
give the whole
life,
tape.
it's a,
Hold this.
we do
Hold
this
it.
case every day in each cath lab, and we stand every day in each cath lab. It's real life. It's not just RCT published, it's real life. What I also want to stress, perhaps, it's we don't care so much about the balance between smooth muscle cells and calcification. What I mean, when we have huge calcification, the risk of intimal hyperplasia is pretty low, and the main focus is about scaffolding. On the contrary, when we have few calcification, I am concerned about the risk of intimal hyperplasia. And so we know that Supera, for example, in this huge calcification, I think to use a bare metal stent, could make sense because the problem is related to the scaffolding and not to the intimal hyperplasia.
Tell Sydney I want her to hit view roadmap for me. I'll tell her.
Yeah, I mean, I always try.
Can she hear that? Yeah, hit view
DCB and
roadmap.
spot stent, but my threshold for stenting this would be very low. You're not going to pay the price if it restenoses. You deal with it. You haven't taken away any options down the road, so I wouldn't sweat it if I had to stent the whole thing.
Yeah, in this particular case, I mean, it was just a really nasty spiral dissection, pretty much from stem to stern. So clearly, you're going to need definitive scaffolding here in the hopes of getting not only a good acute result, but also a better long-term result. So I agree with Chris here. I would scaffold the whole thing.
Jose?
Yeah, I don't think you're going to get a better result, or at least an immediate result, with a metal scaffold, as Chris has done. But I think it's not unreasonable either what Eric had mentioned in the past, perhaps stenting in the distal portion of that stenosis and DCB proximally would not have been an unreasonable approach either.
Steve?
I think if we've managed to wire the lesion intraluminally, I think it would be nice to see if we can avoid a stent with some either arthrectomy or a scoring, a serenator, or plug modifying device. But of course, if you can't, then luminal supremacy comes first, and definitely a drug-eluting stent. I'm not sure I would personally put a superior in because of the size of the vessel could be a problem. So probably there are not a lot of great options here in either a DCB or a DES. But for sure, if you're going to put a drug-eluting device, it would be total lesion coverage, a la coronary.
Perfect. David, your call?
So we actually have data out of Sinai to show that any residual dissection more than 30% does affect patency rates. And in this case, unfortunately, because of the reentry, the dissection extends from the proximal to the distal end. I definitely would plan to stent the entire lesion. Also, I think IVUS gave a lot of good guidance. I think on IVUS we saw that there was some underappreciated calcium not seen on the angiogram. So I think full extent lesion stent in this case would be a very great decision, and I would proceed that way as well.
Perfect.
In such a patient, I don't like stenting. I usually do TCP plus spot stenting, but in such a patient with such a lesion, with all these kind of dissections, I would go for the full metal jacket here. My only question is maybe would the retrograde excess have avoided stenting the whole lesion? Maybe then the intraluminal approach could have been maybe better.
Yeah, I think that's a good point. So I think Dr. Metzger is going to do the final ballooning, and I think we'll finish the talk and we'll come for the final result. Dr. Metzger, is that okay?
Yeah. Yep, absolutely.
Yeah. Dr. Metzger?
Yep. Let me wrap you up here. And I can't believe my good friend Peter Sukas was just gooning on me. Even as bad as Metzger's, I heard him say. Are you kidding me, Peter? I love you, man. All right. So before that, here's our balloons. These are 5 by 150 balloons. They inflated pretty well, expanded pretty well.
We can't.
And
Yeah.
the angiograms. Okay. And, this is a problem with nitinol, and somebody mentioned interwoven. That's why I much prefer interwoven, because you don't get this little bit of recoil there. But if you look there, this is widely patent. And most importantly, folks, let's go down to what we're here for to begin with, is to get blood to her foot. Remember how long it took there to get there before? I think that we're significantly improved on our flow to the foot. We're going to keep her pit bull away from her big toe. And I think even though I would have preferred not to leave nitinol, and Marion's right. I mean, the retrograde, had we gone in and stayed intraluminal or met in the middle, I think we're okay. It was kind of a very ambiguous cap there to begin with. So it was a challenge. Now, I've got an IVUS catheter in there if you want to see one quick run, and then we'll call it a day.
Sure.
All right, you want to show us, Dylan?
We have 1 minute.
Again, this is what we got here. Okay, here we go. Go ahead and record, please. Somebody record. Right, okay.
FaceTime. Yep.
So, we got a good lumen. Do you still see that D shape there?
Yeah.
That's the problem with the nitinol. You get a 0 when you use an interwoven. But most of it's pretty good. We'll probably expand that a little bit more. And for sure, right there, we need to expand a little more. And we got into, we're doing okay in the common femoral artery. So I think we're stopping for there in terms of the delivery. We're going to hit that a little bit more with the non-compliant and see if it'll stay there. But truly appreciate everybody's help. And again, always a pleasure, PK, just to hear that you're smiling and to transmit to your awesome meeting. So thank you all very, very much.
3 times in a row, I can tell you that, okay? So I think it's a wonderful case, Dr. Metzger. Congratulations. Beautiful. Thank you so much for doing this for us.